in this video, we will discuss about sex hormones. The major endocrine glands which secrete sex hormones, in the female it is ovary and in the male it is testis. Ovaries secrete estrogen and progesterone, whereas testes secrete testosterone. So we will discuss about these hormones in this video. We will start with estrogens. Now we will be discussing a little bit about natural estrogens, not details. Natural estrogens, we have three types of estrogens in the body. They are E1, E2 and E3. E1, E2 and E3. E1 is called as estrone. E2 is called as estradiol. And E3 is estriol. E1 or estrone is the predominant estrogen in the postmenopausal period. In postmenopausal female, the predominant estrogen is E1. Whereas in reproductive age group, predominant estrogen is E2, and in pregnancy, the main estrogen in the body is E3. E1 is the main estrogen in postmenopausal female, E2 in the reproductive age group, and E3 is in the pregnancy. So basically we want try to remember these things, and it is very easy to remember. You can see E1 is estrone. The name itself says 1. It is E1. Estradiol, it contains di in the name, so it is E2. And estriol, it contains tri in the name, so it is E3. Now you can easily see that in reproductive age group, we have husband and wife. So 2. So when we have 2, the main estrogen is E2. Now in pregnancy, we have 2, husband and wife plus baby, 3. So we have total 3. So it is E3 in pregnancy. Whereas in postmenopausal female, the female remains alone. So 1 only. So it is E1. Okay? So E1 is the main estrogen in postmenopausal female, E2 in reproductive age group, and E3 in pregnancy. The drugs working on estrogen receptors, they may be divided into selective estrogen receptor modulators, SERM. They may be selective estrogen receptor down regulator, SERD. They may be selective tissue estrogen activity regulator, or STER. And lastly, the drug may be aromatase inhibitor. So these 4 types of drugs we will discuss one by one, starting from SERM. Selective estrogen receptor modulators. So as the name tells, they will selectively modulate the estrogen receptors. Means these will not be estrogen receptor agonist at all the places. These will not be estrogen receptor antagonist at all the places. That means in some tissues they are agonist to estrogen receptor, in some tissue they are antagonist to estrogen receptors. Yeah. So for these drugs to understand, first we need to know what are the normal functions of estrogen. So estrogen we already discussed act at 5 main places: bone, blood, breast, endometrium and liver. And in these places estrogen increases something, like in the bone estrogen inhibit osteoclast, so it increase the formation of bone. In the blood it increase the HDL to LDL cholesterol ratio, means it benefit the lipid profile. In the breast it increase the risk of cancer. In the endometrium also it increase the risk of cancer. And in the liver it increase the clotting factors, which can result in thromboembolism. These actions we already discussed. Now, apart from these actions, 2 things they manifest when estrogen is not present. And these two things are, one is called hot flushes. Hot flushes or vasomotor symptoms, they occur in postmenopausal period when estrogen is not there. And second, estrogen deficiency, it can result in vaginal atrophy. So in postmenopausal female, there may be vaginal atrophy. Clear? So now, if we want to develop a SERM, the ideal SERM will have beneficial effect at most of these places. So ideal SERM will be that which is agonist in bone and blood, increase bone formation, increase HDL, decrease LDL. Ideal SERM will be antagonist in the breast, endometrium and liver. Because we want to decrease breast cancer, we want to decrease endometrial cancer, we want to decrease the risk of thromboembolism. But till date, we are not able to form any ideal SERM. The one which is closest to ideal, we already discussed that, is raloxifene. Raloxifene is closest to ideal, means it has all the beneficial effect except the last one. It is agonist in bone, formation of bone increases, agonist in blood, increase HDL, decrease LDL, antagonist in breast, decrease the risk of breast cancer, antagonist in endometrium, decrease the risk of endometrial cancer. So all four are good. But the only problem is it is agonist in liver. We wanted antagonist, it is agonist in liver. So that means the major side effect of raloxifene is thromboembolism. So raloxifene, it can be used in postmenopausal osteoporosis, treat osteoporosis. Additional advantage is benefiting the lipid profile. Another advantage, it decreases the risk of breast and endometrial cancers. But the main side effect is it causes thromboembolism. Okay. Then after raloxifene, we formed another SERMs. These include tamoxifen, doloxifene, and toramifen. Now these SERMs, will they be better than raloxifene or worse than raloxifene? Obviously worse. We already told that the best SERM we have is raloxifene. So to remember these, make good at first three, make one more bad. So these drugs are agonist in endometrium also. So they are beneficial on first three places. That means they are agonist on bone and blood and antagonist in breast, but we wanted. But they are agonist in endometrium and liver, which we do not want. So that means they benefit the bone, increase formation of bone, benefit the blood, increase HDL LDL ratio, benefit the breast, means decrease risk of breast cancer, but they increase the risk of endometrial cancer and they increase risk of thromboembolism. So these drugs, they are very, very strong antagonist on breast tissue. So their major clinical use is treatment of breast carcinoma, with additional advantage that they increase the formation of bone and they increase HDL LDL ratio. But with the two disadvantages, they increase the risk of endometrial carcinoma and they increase the risk of thromboembolism. Okay, if you want to remember them, it is easy. You can remember these are beneficial on 3 B's. So organs which start with B, they are beneficial. So they are beneficial on bone, breast and blood. They increase formation of bone, decrease breast cancer and increase HDL LDL ratio. So these are beneficial on 3 B's, but they are harmful on endometrium and liver. Clear? Then the next group of SERMs is clomiphene citrate. Clomiphene is a SERM. It is estrogen receptor antagonist, mainly in pituitary. So before discussing clomiphene, we'll discuss some basic thing. Hypothalamus, it secretes gonadotropin releasing hormone, which stimulate the anterior pituitary to secrete gonadotropins. That means luteinizing hormone and follicle stimulating hormone. And these gonadotropins, they stimulate the ovaries to secrete estrogen. This is the normal situation. Whenever the level of estrogen rises, it will exert feedback inhibition on pituitary and hypothalamus. This we all know. Now, clomiphene, it is an estrogen receptor antagonist in the pituitary. Means when estrogen is exerting feedback, it will act through estrogen receptors. And clomiphene block those receptors. That means feedback inhibition cannot occur. So that means estrogen is not able to inhibit the gonadotropics. That means estrogen, when they are not working, that means the level of LH will rise. And when LH rises, we know LH is required for ovulation. So that will result in ovulation. Okay? So clomiphene, because of this mechanism, is used for anovulatory infertility. So clomiphene is used for treatment of anovulatory infertility. It stops the feedback inhibition, LH rises, and when LH increases, that lead to ovulation. Clear? So used for infertility due to anovulation, and the main side effect of clomiphene is it can result in multiple pregnancy. So there is high risk of development of twins or triplets when we use clomiphene to induce fertility. Okay. The next sum is ospamifene. Ospamifene, it is estrogen receptor agonist mainly in vagina. So what it will do? It will prevent the vaginal atrophy in the postmenopausal period. And if vaginal atrophy occur, there will be pain during sexual intercourse. And the pain during sexual intercourse is called as, yes, dyspareunia. Dyspareunia. So ospamifene is specifically indicated to treat the dyspareunia due to vaginal atrophy in postmenopausal females. So when we give ospamifene, vaginal atrophy is reversed. So painful sexual intercourse do not occur. Clear? Then lastly, we have a sum called as ormeloxifene. The other name of this is centrochromen. This is mainly estrogen antagonist in the endometrium, and it is used for contraception. The common name, brand name by which it is available is called Saheli. And the most important thing which is asked in the Viva exams, this is the drug which is formed in India. It is synthesized in India, and this drug is synthesized at Central Drug Research Institute, Lucknow. This is developed by CDRI India, Lucknow, and from the name you can remember, its name is centrochromen. Cent means Central Drug Research Institute, Lucknow. So these are the important points regarding the SERMs, the first group of drugs working on estrogen receptors. Okay. Then we have a second drug which is called selective estrogen receptor down regulator. D means down regulator. We know that tamoxifen, it is antagonist to estrogen receptor in the breast tissue. So tamoxifen is used for breast cancer. But many patients of breast cancer, they are resistant to tamoxifen. If tamoxifen do not work, then what we want? Basically in breast cancer, what we want? Estrogen should not work. So tamoxifen is blocking the receptor. But if the receptors are too many, then tamoxifen is not able to block them properly. So what we want, that number of receptors should decrease. So this is a drug which we have formed which will selectively down regulate, means decrease the number of estrogen receptors. It is not blocking the receptor, it is decreasing the number of the receptors, and the name of the drug is fulvestrant. Fulvestrant. It is selective estrogen receptor down regulator mainly in breast tissue. It mainly decreases the estrogen receptors in the breast. From the name you can remember, ester means estrogen and means antagonist. Function similar to estrogen antagonist. It is not antagonist. It decreases the number of receptor. Function similar to estrogen antagonist. It is indicated in tamoxifen resistant breast cancer. Tamoxifen resistant breast cancer, we can use fulvestrant. So what will be the advantage of fulvestrant? Obviously, one, it is more effective than tamoxifen, because if tamoxifen is not able to work, even then it can work. Number two, it is acting only on breast tissue, do not act at any other place. So that means it is more safer. It do not cause thromboembolism that is caused by tamoxifen. And third, it is very long acting also. So fulvestrant has following advantage over the tamoxifen: one, more effective; second, more safer; and third, longer acting. Okay. Then the third group of drugs acting on estrogen receptors, it is called as STEER. STEER means selective tissue estrogen activity regulator. The example of this drug is Tibolone. Basically, Tibolone work like SERMs. Just like SERMs, it will be acting like estrogen in some tissues. It will be acting opposite to estrogen in some tissues. But what is the difference is, the SERMs, they themselves stimulate the estrogen receptor in some tissues, and they themselves block estrogen receptor in some tissues. But Tibolone do not do so. What happens is, Tibolone is metabolized to different products in different tissues. Some tissues metabolize Tibolone to form estrogen agonist, and some tissues metabolize Tibolone to form estrogen antagonist. So Tibolone form different product in different tissues. That's why it is called as selective tissue estrogen activity regulator. The final effect is same. The major action of Tibolone is, it acts as estrogen agonist in the vagina as well as on the blood vessels, and third, on the bone. So basically, it prevent vaginal atrophy, it prevent the vasomotor symptoms, and it also prevent the osteoporosis. So all these things we are looking for in a drug which is hormone replacement therapy, postmenopausal female. So Tibolone is sometimes also known as designer HRT. Tibolone is also known as designer hormone replacement therapy. Okay. Then the last group of drugs, these are called aromatase inhibitors. You must have heard about a term called as postmenopausal breast cancer. Have you heard? Yes. So postmenopausal breast cancer. What is the meaning of this? Meaning, after the menopause, breast cancer. What happens during menopause? Estrogen production stops. So when estrogen are not produced by ovary, how the breast cancer occurs? We know estrogen causes breast cancer. So when estrogen is not there, breast cancer should not have. But still breast cancer occurs. So here the breast cancer is occurring due to estrogen produced somewhere else. It is not due to ovary. It is from somewhere else. And what is that somewhere else? Yes, adrenal gland. Our adrenal gland, it is producing the androgens. Remember, adrenal gland produce three type of hormones: glucocorticoids, mineralocorticoids, and sex corticoids. The sex corticoids produced are mainly androgens, and these androgens are converted to estrogen with the help of an enzyme aromatase. So that means if we inhibit this aromatase, then estrogens will not be produced. So we can treat the breast cancer. But these drugs will be more effective when ovary is not working. Because if ovary is already producing a lot of estrogen, then it will not be much effective. So aromatase inhibitors are indicated only in postmenopausal breast cancer. It is not indicated in premenopausal breast cancer when ovary is working. And the drugs which are aromatase inhibitors are letrozole, anastrozole, and exemestane. These are used in postmenopausal breast cancer. Clear? So these are the important drugs which act through the estrogen receptors. Okay. Now progesterones, they are basically used for important two functions. One, in hormone replacement therapy. Second, as a component of oral contraceptives. But they can be used for many more functions, like they can be used for fibroids, dysfunctional uterine bleeding, and many more conditions. Now progesterones are divided into 4 generations. First generation, second generation, third generation, and fourth generation. They are divided into 4 generations. The first generation progesterones, they are called estrogens, whereas second generation, they are called as gonines. Third and fourth do not have any specific name. First generation are called estrogens, second are called gonines. Now the examples of these, the first generation progesterones, these include norethindrone, and norethindrone. Whereas the second generation progesterones, which are also called gonines, they include norgestrel and levonorgestrel, commonly written as LNG, levonorgestrel. So ethindrone and ethynodrel, when they are norethindrone, norethynodrel, they are estrogens or first generation, whereas norgestrel and levonorgestrel, they are second generation. Now the third generation progesterones, these include desogestrel, norgestimate, and gestidone. So desogestrel, norgestimate, and gestidone are examples of third generation progesterones. And lastly, the fourth generation progesterones, these include nomegestrel and drospirenone. So these are the 4 generations of progesterones. Estrogens or first generation are norethindrone and norethynodrel. Gonines or second generation are norgestrel and levonorgestrel. Third generation include desogestrel, norgestimate, and gestidone. And fourth generation are nomegestrel and drospirenone. Now what you need to basically see is, as the generation increases, the potency increases. So you need to remember, as the generation increases, the potency increases, means first generation have very low potency, second generation have slightly more, first generation have low, second generation have slightly more, third have still more, and fourth are most potent progesterones. So potency keep on increasing. But more important to remember, progesterones have one major limitation, and that is their androgenic activity. Most of the progesterones contain androgenic activity, which can lead to hirsutism, acne, and other problem of androgens. Now the androgenic activity keep on decreasing with the generation. So first generation have very strong androgenic activity, second generation have very less androgenic activity, third generation have negligible androgenic activity, whereas fourth generation they have anti-androgenic activity. Rather than androgens, they have anti-androgenic activity. Okay? And this last drug, drospirenone, in addition to the fourth generation progesterone properties, this also has anti-mineralocorticoid receptor activity. That means it blocks the mineralocorticoid receptor. So it, rather than causing retention of salt and water, it causes excretion or removal of salt and water from the body. Clear? So these are the important type of progesterones which are used in market or in clinical practice. Clear? Similar to SERMs, we have drugs called as SPRM. That means selective progesterone receptor modulators. That means they are agonist to progesterone receptor at some place, antagonist at some other place. So we will discuss about these SPRMs here. The main drugs in this category are mifepristone, onapristone, and ulipristal. Starting with mifepristone, the major actions of mifepristone is it is progesterone receptor antagonist in the uterus. In the endometrium, it is progesterone receptor antagonist, but it is highly non-specific, means it not only blocks the progesterone receptors, but it is also an antagonist of glucocorticoid receptors. And it is also antagonist of androgen receptors. So mifepristone blocks progesterone receptors, glucocorticoid receptors, as well as androgen receptors. The major uses of mifepristone you can remember from mifepristone. M stand for morning after pills. So we'll discuss little while later. Morning after pills means these are drugs used for emergency contraception. Okay? So mifepristone is one of the emergency contraceptive. Then I means induction of abortion. Particularly in early pregnancy, we can use mifepristone to induce abortions. Then F means fibroid. We can use mifepristone in fibroid. E means endometriosis. We can use it for endometriosis also. PR means progesterone receptor positive cancers. Mifepristone can be used to treat progesterone receptor positive cancer, and one cancer obviously we all know is breast cancer. We know breast cancer is increased by estrogen as well as progesterone. Name one more cancer where progesterone receptor positivity may be seen. Yes, it is meningioma. So it can be used for progesterone receptor positive meningioma also. Okay. Then I means increase. S means steroids. Remember, progesterone, apart from progesterone receptor antagonism, mifepristone is also glucocorticoid antagonist. So it can be used when glucocorticoids are high, and excessive glucocorticoid is known as Cushing syndrome. So mifepristone can be used for treatment of Cushing syndrome also. So these are the important uses of mifepristone. Okay. Then the second sum, onapristone, the name says onapristone, it says only, ON matlab only, PR means progesterone. So it is only progesterone antagonist. It do not block the glucocorticoid or androgen receptors. It block only progesterone receptors. So it is also indicated in induction of abortion. Onapristone is also indicated for abortion. Okay? Now coming to ulipristal. Ulipristal is also SPRM, and its major clinical use is as emergency contraceptive. Morning after pill, ulipristal. But special thing to remember, all other emergency contraceptives, they must be given within 72 hours to prevent pregnancy. Whereas ulipristal is the only drug which can work even after 72 hours. So this drug can be given up to 120 hours of unprotected intercourse. That means after 72 hours, for 72 to 120 hours, this is the only drug which can prevent pregnancy. And this is given as a single dose of 30 milligram for emergency contraception. So these are the important points regarding the SPRMs. Okay. So now we can move to our last hormone, which is testosterone. This is the male hormone. Now, important thing, testosterone, it does some functions, but some functions of testosterone are done by conversion into dihydrotestosterone. And this is done by an enzyme called as 5-alpha reductase. So 5-alpha reductase, it converts testosterone to dihydrotestosterone. Dihydrotestosterone, it can work on androgen receptors to produce the effect. Testosterone itself can also work on androgen receptors. DHT can also work on androgen receptors. First, we need to know what are the functions of testosterone and what are the functions of dihydrotestosterone. The functions of testosterone you can remember from fish. Important actions for which we require testosterone itself, it is feedback inhibition. So feedback inhibition at pituitary and hypothalamus, it is done by testosterone itself. Then I means internal genitalia. Testosterone is required for development of internal genitalia. S is spermatogenesis. Testosterone is required for spermatogenesis. And lastly, H for hematopoiesis, formation of blood. Testosterone is required for hematopoiesis also. So these are the actions of testosterone. Then actions of dihydrotestosterone, DHT. DHT actions you can remember from sexual. S for secondary sexual characteristics. So DHT is required for secondary sexual characteristics like male pattern, this sound, male pattern voice, or male pattern hair growth, mustaches, etc. These are secondary sexual characteristics. It requires DHT. Then EX means external genitalia. So development of external genitalia is done by DHT. Internal genitalia by testosterone, external by DHT. Then U means urine. Excessive DHT can result in urine problem. Just to remember, basically DHT is required for growth of prostate. And we know prostate excessive growth can cause BHP, which can result in urinary problems. Then A for anabolic. DHT is a powerful anabolic hormone. Then L means loss of hair. Male pattern baldness. It is caused by DHT. So these are the actions of testosterone and dihydrotestosterone. If we revise, testosterone, it is converted to dihydrotestosterone. The enzyme is 5-alpha reductase. This DHT act on androgen receptors. So most of the androgen receptors are stimulated by DHT, but little bit of androgen receptors can be stimulated by testosterone also. And if we talk about prostate, so stimulation of androgen receptors will result in prostate growth of prostate. Now, if we want to decrease the growth of prostate, like in BHP or in prostate cancer, so we want to stop this part, and we have two options. We can inhibit this enzyme, or we can block androgen receptors. The drug which inhibit the 5-alpha reductase, the drug is finasteride. And a new drug in this category is dutasteride. So these act by inhibiting 5-alpha reductase. On the other hand, the drug which block the androgen receptors, these include flutamide, nilutamide, bicalutamide, enzalutamide, apalutamide. So any drug which ends with lutamide, it is androgen receptor antagonist. Now if you see which drug out of the two, finasteride group or flutamide group, which drug is likely to be more powerful inhibitor of androgens, which drug is more stronger? If we see carefully, when we give 5-alpha reductase inhibitors like finasteride, they will inhibit the formation of DHT from the testosterone. So DHT will not be able to work because it is not formed, but testosterone keep on working. So it stops the action of DHT but not testosterone. On the other hand, if we have given lutamides which block the receptor, then neither testosterone nor DHT can work. So androgen receptor blockers are more stronger. So when we will want receptor blocker, when we want to totally inhibit the action on the prostate. And which condition? Yes, in cancer. So in prostate cancer, we use glutamides. Glutamides we use for prostate cancer. Whereas 5-alpha reductase inhibitors, they are used for benign growth. So they are used in BHP. So finasteride like drugs are used in BHP, whereas flutamide drugs are used in prostate cancer. Clear? Second important use, we can use 5-alpha reductase inhibitors also for male pattern baldness. Remember, DHT also causes male pattern baldness. So for male pattern baldness also, we can use finasteride like drug, which is called as androgenital alopecia. Male pattern baldness, it can also be treated by finasteride. So finasteride can be used for BHP, it can be used for alopecia. Clear? But because all of these drugs are inhibiting the androgen function, so all of these drugs can result in impotence as the side effect. Impotence is the adverse effect of all of these drugs. Okay. Now moving to the last thing in the testosterone, there is a group of drugs called as anabolic steroids. You must have seen that many guys, they go in the gym, take some steroids and they become bodybuilders. Okay, so these steroids are not glucocorticoids. These steroids are testosterone derivatives, androgens. They have anabolic activity. Testosterone, if we broadly divide the actions of testosterone, it has two main action, but androgenic action, male action, development of male genitalia, spermatogenesis, all these male actions, and second, it also is anabolic. So testosterone has both of these equal activities, 1:1. In case of gym, when we want to develop the body, we want only anabolic action. We do not want androgenic action. So we have developed the anabolic steroids, which have 3 times higher anabolic activity as compared to androgenic activity. So these are called anabolic steroids. And the main examples of anabolic steroids are nandrolone and stanozolol. Nandrolone and stanozolol, these are examples of anabolic steroids, but these are very toxic. They, although the person can develop the body, they will become bodybuilder, but these have many problems. First problem is the person will have development of muscles till the time they are taken. So whenever the person stops them, again the muscles will become flabby like earlier. Second problem, these drugs are hepatotoxic. They can cause liver damage. And third important problem, they can also result in impotence. Because they are androgens, feedback inhibition will occur and that can result in impotence, infertility, all these problems can occur. So these are not usually recommended. And plus, these are under the dope test in the competitive sports. Remember, we will want that if a person is having weightlifting competition, if a person is taking the drugs, he will get undue advantage. So the person should not get this advantage. So in all the competitive sports like Olympics, a test is done before participation in the games, that is called a dope test. So in dope test, we commonly test the anabolic steroids. Clear? So these are the important points regarding the sex hormones.